So, most of us hope, we anticipate, that we will die peacefully. And we see, as in the movies, those last words that we're able to give to our loved ones. We'll be able to communicate our desires right to the end. That's how we envision it. However, what we know is that usually it doesn't really happen like that. 8 in 10 Canadians say that we should start planning early. However, fewer than 44% of us actually do that. And though all of us feel that we should have a discussion with our physician about what our wishes would be at end of life, very few of us actually do that, only 9%. And why so few? Because darn it, it's difficult. Isn't it difficult? And I'm not here to say that I have done it right. In fact, my little mother, who's 92 years old, when she was a mere 85 years of age, one of my friends brought to my attention that I was saying, if my mother dies, not when my mother dies. And she was 85, and I hadn't even broached that conversation with her. When I finally did, she brought out a sheaf of papers and says, well, I was waiting for you to talk to me about it. And she'd already taken care of it. So we may find that it's easier than we think. Gary just forwarded me an article from the Wall Street Journal this week. I don't know if any of you read it, but it showed that physicians do this better, do the advanced care planning better than most of the rest of us, because they know what it's like to not have that done. I have actually done polls of various healthcare groups, and typically, even though we're in healthcare, we haven't had those conversations. However, there is help. And this is a web link that is also on your handout that gives some really good conversation starters, some really good background, some really good reasons, lots of interesting YouTube videos. So my husband has been rather reluctant to have this conversation with me. So I had him go to this website, and it was a good conversation starter. So even in your own situations, not even when we speak about your work situations, this is a good website, and I recommend it. And April 16th has been designated National Advanced Care Planning Day, and so you may be seeing more about that. So let's have the talk. Next topic is hospice palliative care engagement strategy. There has been some significant work at a provincial level this fall, and it is continuing. As Martin said about the primary care initiative, the goal with this as well is to have it coordinated provincially and tailored locally. I won't go into this work at any great length. Gary Switzer did help lead this at the provincial level, so we're very fortunate that Arlene is well connected. Betty Kuchta and I were both on working groups, and so we will certainly keep you posted about that. It was a very fulsome, comprehensive process with 80 people from across the province involved, common consensus, and I have posted the report on our website if you're interested to read it, and there'll be more about this. So Erie St. Clair Progress Report. It's certainly well aligned with the provincial work. And one of the interesting things that has come out of the provincial work is something that Paul mentioned the very first time I met him. So what he said was, well, it seems to me that palliative care is what should be at the end of every chronic care path. At the end of every chronic disease management care path, there should be a palliative component. Seemed quite profound to me at the time, Paul. And provincially, that is one of the things that's coming out, is that truly palliative isn't just cancer. At the end of every chronic disease management care path, there should be a palliative component. And so it fits in well with what we've been talking about this morning as well. We certainly in Erie St. Clair are well aligned with what they're recommending provincially, and we've made many improvements. If you do have insomnia and choose to read the report, because it will cure insomnia, but you will notice that in that report, Erie St. Clair is referred to frequently. And a lot of the frameworks and works that we've been doing are actually used at the provincial level. So one of the things that we've done well, I believe, is that we've systematically planned and then pursued that plan. We've had LIN support, we've obviously had provider support, CCAC hospitals, et cetera, and certainly the support of individuals. I'm going to quickly tell you a little bit about Helen, who was someone that I met in 2006. And Helen, to some extent, represents the before. She was diagnosed with cancer. I met her at a consulting forum where she drove an old lady to come to this forum. Anyway, subsequently, she was diagnosed with cancer. She had care in a number of care settings. And she died in a respite bed. So I'm going to use her own words. Now, just to give you a picture of who Helen was, Maxine was her hero. And we all know Maxine and identify with her. Helen sent me this. If you woke up breathing, congratulations, you have another chance. But these were some of Helen's other words. It seems as if there's really not an appropriate place for me. I hope that I die soon enough so I won't have to move again. And these were her words near the end. It has been a struggle. The physical struggle is one thing, but worse still is the sense that I'm a burden to everyone. Let me be clear, the people are wonderful. And it is as if everyone has to, but it is as if everyone has to go out of their way to actually provide the care and connections that are needed. There just doesn't seem to be a system. That's what you were saying, Betty. It is as if my situation is a one-of, and everyone is piecing it together as we go. Have people not died before me? So that was Helen's experience. So the before, certainly there's always been wonderful caring people, pockets of excellence, but we had care settings and services missing, and we really weren't connected. We had some wonderful levers for change. Certainly this community had a sense of what good palliative care looked like. We had LIN support, and again, that systematic planning. And I've put a planning report in there if you're interested. And so we've, since 2006, been systematically working through those gaps. This is just a high-level framework that we're using. Again, this goes back to Betty's comment about the system. So we can't just look at one part of the system. These are some of the guiding principles, and there's work behind this. So if we look at each of those individual categories, we've made improvements in each of them. And so, for example, one of the standards is that we should have a full continuum of care settings and services. We know that in Sarnia region, we've had the addition of a residential hospice. In Chatham-Kent, there has not been that option. And so we've been given some funding from our LIN to do a feasibility study there. Another gap that was identified was inadequate bereavement support. And in Windsor, Essex, we've had a big success in partnering with CMHA for those involved with complex grief, and we're hoping to move that to the Sarnia, Lambton, and Chatham-Kent area. Another one of the standards is that within every care settings where patients die, there should be access to palliative care. And so when we did our analysis, we realized that in many care settings, there was not access to specialist level care. And so in the home, we have implemented through CCAC and through Aging at Home funding, the palliative care consultation team. which I think you've heard about before. Our regional cancer program in Windsor has initiated a program of palliative care there that they didn't have. And recently we had a request from long-term care to help with some hospice palliative care programming, and so we've done a pilot in the 3 municipal homes in Sarnia-Lambton, and so you can talk to the folks at the back there if you want to have a review of that. Integration, linkages, and education. We've made some wonderful progress in this regard as well. I'm going to quickly skip through these because we want you to have coffee, but in each of these identified categories, we've systematically been able to make improvements. And so the positive outcomes, as Paul mentioned, Erie St. Clair is seen across the province as a best practice example. Many of our gaps are being filled, there's increased collaboration, and most importantly, patients and families are getting better care. So I want to tell you about Kenneth, and I won't say that he's the after, because we're certainly still on the journey, but I met Kenneth in 2009, again as part of our consultation process. Kenneth had mesothelioma, which certainly everyone in this community is very familiar with. He had a better situation than some because he had extra money from WSIB. Kenneth died in 2010 at 72, and he died in a residential hospice. Kenneth received care in a lot of care settings, and he benefited from many of those improvements that we've been able to make. Some of those are listed here. Again, I won't go into that. But these were Kenneth's words. I'm now in the hospice where I will die. Please tell all the people who have cared for me over the past 2 years how much I appreciate them. All the way along, I felt as if together they formed a strong set of arms guiding me through. People from the hospital, the Access Center, the VON, and the hospice all worked together and worked with me. The doctors and nurses are amazing. Obviously, I don't want to die. However, I had my 10, which was more than can be said of many of my friends. I hear all of you talking about a good death. Sounds like an oxymoron until you are near it. I think I will have a good death, and I am not afraid. So more than just the importance for Helen and Kenneth, there's an importance for our system as a whole. You know, if we can get it right for palliative, we can get it right for those bigger systems. And this is from the CHPCA, Canadian Hospice Palliative Care Model. In the end, our society's ability to realize its potential will be related to its success at relieving suffering. The health and compassion of our communities will be related to the degree of integration of hospice palliative care into all aspects of our healthcare system. Thank you.